Dr. Cleary is an associate professor in the Division of Hepatobiliary and Pancreas Surgery at the Mayo Clinic in Rochester, Minnesota. His clinical interests include minimally invasive approaches to surgical treatment of pancreatic, hepatic, and biliary malignancies. And his research interests include the genetic epidemiology of pancreatic and hepatocellular cancers. Thank you very much, Dr. Cleary.
Great, thank you again. I want to thank the organizing committee and the audience itself for a tremendous honor it is to come and address this group. It's an honor and a pleasure to visit this country and to speak among colleagues in this disease. I also want to thank the organizing committee for their flexibility. If this talk seems a little out of place with the previous talks, it's just because my travel is delayed by weather and other related things. So I thank you all for allowing me to address the group here today. And really talking about liver-directed therapy in cholangiocarcinoma as a disease in general. And I wanted to certainly to start talking about the need, because I think this is something that we probably underappreciate, especially in our tumor board settings and discussing patient management. And we, as a surgeon, we're quite well aware that about a fifth or less than 20% of patients with this disease will be amenable to surgical resection at any point after their diagnosis. We know that intrahepatic recurrence or progression is common, and therefore liver-directed therapy seems to make a lot of sense in these patients. We know that liver disease is dominant in terms of, as a main determinant in terms of prognosis. And while we have great benefits in systemic therapy, we know local therapy can prolong survival with fewer side effects, either alone in combination with systemic therapy. But there's obviously a challenge, and obviously the reason why it's an underappreciated aspect of things is, again, because of the challenges that are generic to liver malignancies, but also specific to this disease. And certainly the challenge that we face is that patients with surgically unresectable disease often have large volumes of intrahepatic disease. Certainly in many patients in Asia and in certain viral infected populations, compromised liver function is present in many of these patients, which means that we're concomitantly managing two concurrent diseases, both the liver disease as well as the underlying hepatic malignancy. In terms of the actual biology and anatomy of the disease, intrahepatic cholangiocarcinoma and other cholangiocarcinomas are slightly less vascular than hepatocellular carcinoma, where liver-directed therapy has a much stronger role in the management. We know by looking at these lesions cross-sectionally and pathologically that many of the viable and growing cells are at the periphery of lesions, which obviously complicates localized therapies. And as we know in this disease, we have multiple tumor subtypes with different biologies, different growth patterns, and different extension in terms of the mass forming, the periductal and the intraductal. And these have their own unique properties and challenges that affect liver-directed therapy. So where is the bar in this disease? I think we obviously have talked a lot about this systemic therapy this morning, and we know obviously I think right now the bar in terms of level 1 evidence in this disease starts with the ABC trial. And we know, first of all, that the results of this trial show us that in this patient population, which may not be entirely equivalent to the rest of the patient population we'll be discussing for the rest of this talk, median survival is really in the 8 to 11 month range. And again, these are patients with predominantly a very advanced disease. And so, but that is certainly where the bar is in terms of systemic therapy. Unfortunately, for this talk, this will be the high point of the evidence-based aspect of the talk, because really a lot of the evidence around liver-directed therapy is derived from single-center and cohort studies. When we look at combination therapy, and again, we've looked at that again, we're still looking in terms of overall survivals in the 9 to 11, 12-month range. And again, maybe not the same patient population, but this is certainly where the bar is in terms of comparisons between different approaches. And certainly we've seen lots of exciting data today about targeted therapy, particularly on FGFR1 and 2 alterations. And certainly there's a lot of interest and potential in these type of things. But again, at this point in time, again, maybe not similar patient populations, but again, still progression-free survival ranges in the single digits in terms of months. But that's not to downplay systemic therapy. I think there's been tremendous advantages. But we looked at liver-directed therapy. I think it's been classically divided up into sort of four main categories: the endoscopic therapy, the percutaneous therapies, the vascular therapies, and the radiation oncology therapies. And I think that while this sort of four region classification does very well for the first couple lines of treatment, the exciting thing is these categories start to break down a little bit as we have cross-pollination of these various approaches, particularly in terms of endoscopic delivery of radiofrequency ablation, vascular delivery of radiotherapy. So again, we're seeing lots of breakdown in these in the divisions between these lines of therapy, which I think holds true benefit. And I think that theme of combining approaches may offer certainly a lot of optimism for the future. So for endoscopic therapy, I know this is predominantly used in most of our patients to relieve biliary obstruction for proximal tumors, whether those are intrapancreatic or hilar. Just from a surgical perspective, from preoperative stenting, we've got one randomized control trial and a meta-analysis of about 711 patients from 11 studies that show that preoperative stenting in resectable disease increases the risk of complications, particularly infectious complications, but no evidence in perioperative mortality. There is a debate among the community as to the exact volume of liver that you need to drain prior to proceeding with surgical resection, whether this is a 15 to 30% or a selective liver drainage or whole liver drainage. So there's two ongoing randomized controlled trials that are currently comparing unilateral versus bilateral stenting that are currently accruing, and again, we'll expect hopefully that data in the next few years. We've obviously had a lot of development from a technical perspective in this type of stents that we can offer to relieve biliary obstruction. We started for decades with just plastic stents, and now we have self-expandable metal stents. In many regions, this comparison is particularly germane because of the cost implications here. When we look at the randomized trials in this space, we can see that the self-expanding metal stents have shown superiority predominantly in stent patency, but only modest gains in patient survival. Again, these are predominantly in the palliative setting, but again, what you do see is fewer interventions in the self-expanding metal stent category. When we look at covered and uncovered expandable metal stents, again, significant cost implications for certain countries. We show that while covered stents have significantly less tumor ingrowth, when you look at overall patency because of not just tumor ingrowth but also dislodgement, there really isn't significant differences between covered and uncovered metal stents. So we start to look at actually directed therapy towards cholangiocarcinomas. Again, we start to see some of the evolution of endoscopic therapy, and we now have a number of technologies that we can deliver endoscopically which have a direct treatment effect on local cholangiocarcinomas. Again, these are predominantly for the intrapancreatic and hilar cholangiocarcinomas, so we have radiofrequency ablation. We have photodynamic therapy, which involves the injection of an IV photosensitizer and delivery of light to form an anti-tumoral effect. And we have brachytherapy. I think the photodynamic therapy showed a lot of excitement about 10 to 15 years ago, and there's been less published in this regard, and certainly brachytherapy has not been explored as much, mainly because of complications. But when we look at radiofrequency ablation delivered endoscopically, unfortunately this is the best study that we have at this point, which was a cohort study of 24 patients from India that were treated with endoscopically delivered radiofrequency ablation compared to 40 patients who underwent stenting alone. Again, this was non-randomized comparison, so there was probably a significant selection bias here. The authors there report a 100% technical success rate, and then they actually went on to look at overall survival. And while we see that the usual things that we would expect to predict overall survival, such as age, the ability to receive chemotherapy, and the technical success of the technical result of the study, the RFA and stenting, were all significant in univariate comparisons. The delivery of radiofrequency ablation wasn't significant in univariate, but was significant in multivariate, which is a little bit difficult to interpret exactly what the benefit of RFA there, but there's certainly some interest in this regard for what it would seem to be very limited ductal-associated tumors. For vascular therapy, again, we do, just as we've mentioned previously, we do struggle with the fact that cholangiocarcinomas, particularly intrahepatics, are less hypervascular than HCC, which is what many of these techniques were designed for. And there has been some interest in modifying these techniques that we've used for HCC, and they're well proven in this disease for cholangiocarcinoma with incomplete benefits. So this one of the simplest vascular therapies, which is bland hepatic artery embolization, really relies on the ability to induce tumor hypoxia. The data around this has been relatively limited and not particularly well explored at this point in time. What has been explored is the idea of delivering chemotherapy via chemoembolization. And again, this can be delivered in the terms of microspheres or drug-eluting beads. The literature in this regard, again, in terms of meta-analysis or systematic reviews, has really been complicated by the fact that a number of agents have been used, including cisplatin, doxorubicin, mitomycin. There's not been really very good coherence or data around any one agent per se. But we can see that while very limited complete response rate, we can see partial response rates of 21%, and stable disease of about 54% with regrettably 23% progression. And when you look at the overall survival, again, it's difficult compared groups across various treatment algorithms, but the overall survival is reported in the literature is between 12 and 25 months. Again, because two of the people who invited me were trained at Memorial Sloan Kettering, I don't think I could get through this talk without talking about hepatic artery infusion chemotherapy. So we did, this was published again from the Memorial Group and Nancy Kemeny, who's really led this in many disease groups, and particularly colorectal cancer. But this group does have experience with intrahepatic cholangiocarcinoma, and they reviewed their experience of 236 patients with unresectable intrahepatic cholangiocarcinoma. They divided their group up really into three groups: the ones with distant disease, liver-confined disease, and regional nodal disease. And while they showed that the survivals of these groups followed what generally you would expect in terms of the trends here, where you'd expect patients with liver-only disease to do better than those with nodal or distant metastasis, they really did focus down on this patient population that had either systemic therapy or hepatic arterial infusion therapy plus systemic therapy, and looked at the patterns of response in that group. And when you look at sort of the waterfall plots, again, you can see just based on the fact these numbers, really there was probably selection bias a little bit on the oncologists involved here. But when you look at the waterfall plots, you do see a very encouraging pattern of response in the combination of hepatic arterial infusion chemotherapy as well as systemic therapy with very good partial response and stable disease rates. Really would seem to be an improvement over systemic chemotherapy alone. And when you look at their overall survival, again, you see a potential synergy or added benefit between hepatic artery infusion chemotherapy and systemic therapy. Again, I think this has been an amazing experience from this institution that's been difficult to replicate outside of that institution, but certainly there are many, there should be a lot of interest, I think, in this based on these results. There has been, again, that was a retrospective review. We've recently seen a phase 2 study out of Beijing, again looking at hepatic arterial infusion chemotherapy using oxaliplatin and 5-FU. This was in perihilar cholangiocarcinoma, and the difference between this and the Memorial Group was that these were interventional radiology inserted infusion pumps, whereas the New York series was predominantly surgically inserted pumps. But here you can see again complete response rates in 16% of patients, partial response rates in 51, stable disease in 21, and progressive disease in 10. So very encouraging results, at least in a very small patient population. But what they did actually show, which was actually kind of interesting, was some significant differences in terms of the tumor subtypes, with really significant benefit in the periductal infiltrating subtype over the mass-forming subtype. And this is somewhat of a surprise, I think, both to the authors, but also myself as I read the paper, since this is traditionally a less favorable subgroup of patients. And then when you look at their progression-free and overall survival, again, progression-free survival, you can see, again, the periductal infiltrating group showing a significant improvement over the mass-forming type, with overall median survivals really kind of in the 12 to 15 month range. When we look at other vascular therapies, I think one of the other ones that's gained a lot of traction, both in the United States and internationally, has been selective internal radiotherapy, or SIRT, or as many of us know it, Y90. And that is really a radioactive particle, yttrium-90, attached to either resin or glass beads. And again, we talked about some of those combinatorial effects and therapies. This has both the effect of embolization with the delivery of local radiotherapy. And again, I think as you will, all the radiologists will understand, there's a slightly different pattern and completeness of the embolization, whether you use resin or glass beads. And certainly, but the Y90 agent is one that's been really favored in this technology and seems to be gaining a lot of traction. When we put the results together again in a systematic review, it looks like partial response rates, again, despite the heterogeneity in the literature, seem to settle around 28%, stable disease around 58%, and about 18% progression in disease. Again, the heterogeneity of the literature is seen in the overall survival after treatment, ranging from 4 to 52 months, really showing a vast difference in the way in which this treatment is being used in patients. When you look at the predictors of benefit to this treatment, I think a lot of it seems relatively intuitive in that we look at good performance status, the absence of macrovascular tumor thrombus, modest disease burdens, and peripheral mass forming over infiltrative subtypes. So again, it's very, very difficult to sort of compare these various approaches. There's been really no head-to-head comparisons. Tim Pollock in the United States brought together a number of different centers that were using various regimens of liver-directed therapy and asked them to share their data. He brought together a multi-institutional retrospective review of 198 patients. Again, they had a large patient population who received TACE with a variety of agents, including doxorubicin, gemcitabine, cisplatin, and mitomycin. Drug-eluting bead TACE, including doxorubicin and cisplatin, bland embolization, and Y90 radiotherapy. And again, this was the difference in terms of the treatments predominantly institutional, as most institutions submitted patients who had sort of their favored local liver-directed therapy. So again, selection bias significant in this series. And what they showed was, again, a fairly aggressive group with 80% large lesions, 52% multifocal, and 10 patients having extrahepatic disease. So this was predominantly a liver-dominant patient population. And again, you would expect that 37% had prior therapy, with 11% having recurrence after resection, and a third having prior systemic chemotherapy. And you can argue with the levels of pre-treatment in terms of chemotherapy. Again, most patients had at least 2 treatments, and the major complication rate was fairly acceptable. And in this group, when they put all treatments together, the median survival is 13.2 months. And as you can see, these survival curves are fairly overlapping, really not showing any dominant sort of favored horse in this race, and to determine which was a better liver-directed therapy from the intra-arterial group. And again, the predictors of outcome were the predictable things like ECOG status, complications, and response. And what they did show is that patients that either had a partial or complete response, their median survival was 32.4 months. But but if you had progressive disease, your median survival was 6.4 months, really sort of showing either both the combination of treatment effect, but also tumor biology. The use of ablation, again, has somewhat less use in cholangiocarcinoma over hepatocellular carcinoma from either an operative ablation perspective or a percutaneous approach. Again, we have two dominant ways of dealing with ablation right now, which is either microwave or radiofrequency ablation. Cryoablation has become less favored again, due to complications and effectiveness. And the reason I think the reason there's less experience with ablation than in HCC, I think is fairly inherent in the disease, and that most of our non-surgically treated disease is large and multifocal, and so that also presents challenges for ablation. Where this may play a role is again with patients with underlying liver disease that may not tolerate large resections for smaller lesions. Again, we're reduced to systematic reviews, and if you look at the 7 studies that included 84 patients with intrahepatic cholangiocarcinoma, you can see a 90% technical success rate, which is certainly well below what we would expect in HCC, and 1, 3, and 5-year survivals in the realms of 82, 47, and 24%. The newer technology on the block is something called irreversible electroporation, IRE or nanoknife. The supposed advantage of this is the ability to treat larger tumors, but also to treat tumors around major vascular biliary structures because of the purported lower incidence of vascular biliary injury with this technology. There is, I would say at this point, extremely limited data in this regard, but there may be significant potential in this, particularly for cholangiocarcinoma. So in conclusion, I think there's a variety of liver-directed therapies for both palliation and treatment of cholangiocarcinoma. There are unique and technical challenges as well as biologic challenges in this disease. We've looked at endoscopic therapy that can be used for palliation of biliary obstruction, and the treatment of endoscopically delivered treatment remains investigational. Among the vascular therapy, we have 3 dominant treatment modalities. There does not appear to be any sort of clear winner in this group, and certainly comparative trials would be required. And we still have ablation, which I think will still continue to have a minor component in cholangiocarcinoma. But as we've seen combinations of technology in this field in terms of combining endoscopic and ablative therapy or vascular therapy and radiation, I think really probably the future in this space is probably in the combination of liver-directed therapy plus systemic therapy to really enhance the benefits. And certainly there's been interest in combining ablative techniques with immunotherapy in terms of antigen release and stimulating immune response. And I think those type of hypotheses remain very attractive in this disease. So again, I thank you all for your attention. I thank you for the opportunity and the honor of giving this presentation.
Thank you for that excellent summary of liver-directed therapy in cholangio. Questions from the audience? I have a question. Sorry, was there a question right over there? Yes. Oh, yeah, please, Dr. Chen.
Okay. Thank you. As you know, actually, most of the hepatocellular carcinoma, when liver-directed therapy in combination with systemic treatment other than the immunotherapy was not so successful. So do you think cholangiocarcinoma will be different?
I think one of the challenges in HCC for the combination has been really the limited efficacy of the agents at this point in time in terms of the target therapies, sorafenib, regorafenib, in terms of the modest survival benefits. We certainly, it's also possible we may repeat the same experience in cholangiocarcinoma, but I think as we start to look at the mechanisms of disease and actually looking at targeting therapy, that may have a little bit more benefit. But I think it's a question that's on everybody's mind in terms of their their cautious optimism. Thank you for the.
Go ahead, please.
Thank you for your excellent talk about the liver-directed therapy. As we know, cholangiocarcinoma, one type of cholangiocarcinoma will infiltrate along the biliary tract. How about your experience use the IRE in the treatment of the cholangiocarcinoma, especially the complication after the treatment by IRE?
I don't have a lot of personal experience, or our institution doesn't have a lot of experience with IRE in that periductal infiltrating subtype. Again, because I think the borders of those tumors are sometimes difficult to define, and your actual treatment area can be challenging to define. I think there are some questions in terms of its efficacy, and I think we'd all like to see in terms of IRE some higher level data and prospective studies on that technology. But certainly there is that tempting ability to be able to treat biliary structures and get at least ablative type energy close to biliary structures without damaging that structure. It's tempting, but I think we still need more data in that field.
Yeah, I think Bruno is probably not here, but he gave a talk in the session which earlier that we were scheduled to participate in. So we do use IRE at Anderson, but more for mass-forming cholangio. And like Dr. Cleary described, those are more discrete lesions. And we don't really use it for the introductal because it's hard to tell where it's going. And, again, there is no great randomized data. My question, Sean, is how do you choose sequencing of liver-directed therapy, systemic therapy? Do you have a way to go about, say, Y90 or other treatments earlier versus later?
Sure. Yes. As you know, it's a bit of a there's no data to drive these decisions, and I think where we've looked to use liver-directed therapies again has been in that liver-dominant group where patients either have predominantly multifocal disease or large unresectable disease. We generally start with systemic therapy and look to at least achieve disease stability or even partial response on systemic therapy. And once we feel that we've determined the biology and that really the liver dominance is going to determine that patient's outcome, then look at adding liver-directed therapy. And again, what we've used at our center has evolved and changed a little bit. The Mayo Clinic campus in Florida has been a very strong proponent of using Y90, and we've seen some good results in that regard. But that we usually, at least in Rochester, have looked for stability on systemic therapy before starting liver-directed therapy.
Dr. Rocha.
Yeah. Just building on Dr. Chen's question, I think what would be very exciting to do is do some the Expandable work with ablation and immunotherapy, because that's, I think, a whole new open, potential field of investigation. Just curious what your thoughts.
Yeah, I think that where looking at antigen release and inflammatory stimulation around ablative technologies, it's very, very tempting. I don't think we have great data in that regard, but I think that it certainly, again, in a disease where ablation has a limited role, it'd be interesting to tell. I don't think we have that kind of hypothesis applied to other liver-directed therapies in terms of the inciting immune response. Again, Y90 doesn't appear to be a good candidate for that type of approach, but certainly it's appealing. The challenge is really just many of these patients just don't have lesions where you would achieve a significant therapeutic benefit with an ablative-like technology. But however, if we talk about endoscopic delivered ablation, in reference to the periductal infiltrating subtype, if we could get an ablation probe up into the intrahepatic bile ducts, that may have some interest there.
Thank you very much, Dr. Cleary.